also an honor for me that I am presenting talk in front of Madan Kapre sir, Thakin Kapan sir, and after them also. So today I will be sharing on peri-operative and post-operative management, especially for hypoparathyroidism. It is one of the most common thyroid surgery complication and one of the most important also. Nerves we are all able to save, but parathyroids definitely is one of the most important. And take my words, the word of ablation is increasing because of this complication only. Prevention starts before the incision is made. The patient selection must be accurate. We should not do inadvertent or unindicated surgeries. The indication should be very genuine ones. How to do proper assessment? Biochemical, very important. Serum calcium is mandatory before all thyroid surgeries. Make it very clear, do not operate before doing serum calcium. If possible, do a vitamin D and PTH also. Imaging studies are very important. Before surgery, high resolution sonography, everyone does. CCT, when there's a large goiters, malignancy, retrocerebral extension, CCT is indicated. All these techniques help to find out whether there is high calcium coexistent leading to hyperparathyroidism along with multinodal goiter or malignancy. This pathway is very important, the vitamin D pathway. If we correct this thing before surgery, our rates of hypocalcemia will drastically drop. I have pointed out in the red circles the cholecalciferol vitamin D3 that we all know we give commonly to the patients. It goes and converts into the liver in calcidiol and in kidneys with the help of 1-alpha hydroxylase to calcitriol. Two components you should remember, cholecalciferol and calcitriol. We commonly use both these compounds very oftenly in thyroid surgery patients. Vitamin D replacement. There are many preparations of vitamin D. 1000 units, 2000 units, 60,000 units. There are many ways to give. If you are having sufficient time for thyroid surgery, adequate replacement time is there, then give weekly with 60,000 units. If you are going to operate soon, then it is also indicated you can give 60,000 units on a daily basis for 5 days. After weekly replacement, if you have sufficient time, then keep on continuing the vitamin D replacement monthly. Many times, the people are using 1000 or 2000 units per day also. That is also sufficient. Kidney failure is a special case. Suppose you are going to operate on a kidney failure patient, total thyroidectomy done. In kidney failure, there is a 1-alpha hydroxylase deficiency because of the failure. Kidneys are not working. So calcitriol is not formed. Here, if you give the vitamin D in cholecalciferol form, it will not work. We have to use calcitriol in these patients. Coexistent hyperparathyroidism in the cases of thyroid nodules. It is mandatory, as I previously told, it is mandatory to do serum calcium, classify whether it's hyperparathyroidism present or not, and also classify what kind of hyperpara it is, primary or secondary. Pre-op confirmation is essential. We do in all our patients. And then appropriate imaging studies to find out whether there's a parathyroid adenoma or multi-gland disease. Bone health assessment is essential in coexistent hyperpara patients because if the bone health is very bad, we are going to face hungry bone syndrome after surgery. The hypocalcemia and hypoparathyroidism will continue for long. As we all know, sir has shown that causes of injury to parathyroid glands can be many. Devascularization, inadvertent removal, trauma to the gland directly, or thermal injury. How to prevent them? Surgical extent is very important. Nowadays, we are saying that less is more. So if not indicated, don't go for total thyroidectomy. Do a lobectomy or a hemithyroidectomy. It will prevent at least other side parathyroid glands. Use of surgical agents, I have found myself very useful all this, especially the harmonic focus and imaging, fluorescent imaging. Fluorescent Dr. Thankapan has already shown. Harmonic I will show. So I operate all my cases with harmonic focus. I don't use any clip, any suture anywhere in the thyroid bed. And we do have very less portion of hypocalcemia and hypoparathyroidism. This is a small video. Sorry. So in this video, we are showing the dissection at the superior pedicle. The harmonic is being used. It is dissecting the vessels of the superior pedicle. This is the medial dissection. The medial dissection is going on. Then we are taking the pedicle outside, outwards, lateralizing it. And then the posterior dissection, and here at this posterior point we will find the superior parathyroid. So we have to be very, very careful. It can be from anywhere from the superior pole till the tubercle of Zucker-Gandil. Anywhere the superior parathyroid can be found. We are always saving it, and dissection is very clear, bloodless fields. No clips are required. All vessels can be ligated with harmonic. Just stay close to the thyroid gland. That's all. We have used harmonic in more than 3,000 cases. See the beautiful dissection. The parathyroids are well preserved. The parathyroids are well preserved. Recurrent ganglion nerve is saved. The green arrows are showing the parathyroids. The yellow arrow is showing recurrent ganglion nerve. Another small video where we are preserving the superior parathyroid. This is the superior parathyroid pedicle. We are holding between thyroid and superior parathyroid. And then even to medial to it, we are dissecting it towards thyroid. So the pedicle is preserved, the vascularity is preserved. At the same time, we have identified the recurrent ganglion nerve, and we are using the nerve monitor also. Autofluorescence. I have seen that almost everyone is using the Ehrlich. These are images from the J&J. Has anyone used the J&J? I don't think so, because it's a newer company. And J&J autofluorescence is far better than Ehrlich. That I found personally. Fluorescence, I'm not going into the detail. This is the case of parathyroid adenoma, which has taken beautifully the indocyanine green dye. Another case where the parathyroid adenoma is there along with the recurrent ganglion nerve, yellow arrow and green arrow. In this patient, there was a coexistent parathyroid adenoma, only one gland on 4D CT scan, system AV and sonography. When we operated, we injected indocyanine green and another gland was picked up on the same side. So we had removed both. Histopath confirmed it was a parathyroid hyperplasia. If we had not removed it, it would have caused the recurrence. So both yellow arrows are showing the parathyroid. With the bigger one was picked up on imaging, other one was picked up during surgery. The single best predictor of low hypoparathyroidism rates is high volume experienced thyroid surgeon performing the operation. Even with this kind of meticulous dissection, extensive dissection, we are able to save the parathyroids and preserve the function of the parathyroids also. This is the case of medullary cancer, extensive metastasis. We had done total thyroidectomy, bilateral central compartment, lateral compartment, even axillary lymph node metastasis. But patient was having no hypocalcemia post-surgery. Post-operative management is also equally important. We as a surgeon should know it. The symptoms, please ask the patient, are you facing any kind of tingling or numbness in the extremities of perioral region? Any spasms in the hands or feet? Check the Kostek sign, Struzius sign. It's very commonly performed, easy to do. If positive, think that the hypocalcemia is there. Post-operatively, serum calcium. What we do, one serum calcium as the patient is shifted in the ward after surgery, again in the next morning. Remember one thing, serum calcium drops after 2 days, not immediately. PTH drops immediately. So Even after doing the serum calcium, if we see the trend, and if the trend is towards decreasing, start oral calcium and vitamin D supplements depending upon the severity of hypocalcemia. PTH, it's not mandatory to do. Some centers do, some not. It's not required always. Magnesium is very important. Do we do magnesium after thyroid surgery in our patients? We should do in the cases of refractory hypocalcemia. When we are giving calcium, it is not getting recovered, we should do magnesium. Role of other parameters, vitamin D and phosphorus. Vitamin D we have done pre-operatively, so it is not required to do post-operative. Phosphorus we can do because if it is high, it is showing hypoparathyroidism. Role of diet is very important. Always advocate the patient to take calcium-rich diets like milk, yogurt, cheese, paneer, etc. Calcium supplements, oral or IV, as per the severity. We can give IV calcium in the ward also. We had fought with the sisters. Sisters initially told no, shift the patient to ICU. It is not required. If we are giving slow IV infusions continuously, it can be given in the wards, but it's usually rare. Vitamin D supplements, as I previously told, cholecalciferol or calcitriol. Calcitriol is commonly coming with the calcium tablets in the calcium carbonate calcitriol form of cholecalciferol also. Avoid overhydration. When we do overhydration, it reduces serum calcium. And diuretics. Diuretics, especially the furosemide or loop diuretics, causes calcium excretion. So avoid them. See what antihypertensive patients are taking. If loop diuretics are there, change them. Ask your cardiologist to change them to some other diuretic or some other antihypertensive. Hypomagnesemia in refractory. Magnesium is essential for PTH secretion and PTH receptor action. Low magnesium leads to impaired release of PTH and end organ resistance to PTH. Functional hypoparathyroidism and hypocalcemia is there. Thus, even if parathyroids are anatomically preserved, hypocalcium may persist until magnesium is corrected. How to give it? Oral or IV? IV preferably in the ICU setting, but IV is usually not required. Oral magnesium is sufficient. Teriparatide. How many have used it? 40 injections. 20 units subcutaneously once or twice a day. It comes as 750 units vial. So teriparatide is by many companies like Eli Lilly, etc. So indications are severe symptomatic hypocalcemia after thyroidectomy, not controlled with calcium and calcitriol. Patients requiring prolonged IV calcium support. Chronic permanent hypopara, where conventional therapy fails or causes renal complications. It can be given 20 units microgram subcutaneous once daily or twice daily. Individualization based on calcium phosphate and urinary calcium. Duration usually 2 to 6 weeks, means one vial is usually sufficient. Permanent hypopara may require quite long-term therapy, but cost is quite high. The 40 is costing around 15 to 20,000 per vial. So